we are going to review arterial blood gas analysis. This video is not really for people who are learning blood gas interpretation for the very first time. It is mainly for those who have studied it once but couldn't fully understand it, or for those who feel they cannot apply it well in clinical practice. For detailed textbook level interpretation, please refer to other resources. Here, I'd like to give you a simple, practical way to understand blood gas analysis, something you can use immediately in real clinical care. When people hear blood gas analysis, many tend to focus directly on numbers such as pH or PCO2. But in real clinical practice, we always start with the patient, with their condition, and then obtain the blood gas. So first, let's make one thing clear. When do we actually order a blood gas in clinical setting? We use it when the patient may be in danger. For example, when we want to confirm whether the pH is shifting toward acidosis. We also use it in patients with COPD, diabetes, or those on dialysis, when we need to understand their current CO2 or bicarbonate status. And because blood gas analyzers are available in ER and ICU, we can get information instantly. This is the biggest advantage. Keep this in mind as we go through the interpretation. Before looking at the numbers, start by asking, is there respiratory acidosis or is there metabolic acidosis? Could this be COPD exacerbation, pneumonia, or diabetic ketoacidosis? Also, ask yourself, is this an acute problem or is it chronic? Forming this hypothesis at the beginning is not emphasized much in classroom lectures, but it is one of the most important steps for improving your clinical reasoning. Let's look at the number. The first thing to check are the changing in PCO2 and bicarbonate. In respiratory acidosis, CO2 goes up, metabolic acidosis, bicarbonate goes down. If these changes doesn't match your initial hypothesis, go back to the patient's condition and reconsider. Next, we check whether the compensation is appropriate. If CO2 is elevated as expected, the kidney restricts bicarbonate excretion, so bicarbonate also rises. In metabolic acidosis, bicarbonate is low. Respiratory compensation lowers CO2. Respiratory compensation is first within few hours. Renal metabolic compensation is low, 3 or 4 days. If compensation is outside the expected range, think about mixed acid-base disorders. High CO2 but low bicarbonate. High bicarbonate but low CO2. This combination suggests something more complex. Now check the pH. Ask whether the changes in CO2 and bicarbonate from a single constant story. If pH is markedly abnormal, compensation is incomplete. I mean, compensation is not enough to make pH normal. If pH is near normal, complete compensation, or a mixed disorder. If the movement of pH is unexpected, go back again and review the history and clinical information. In step 4, based on everything so far, we create a final interpretation. Respiratory acidosis plus metabolic acidosis, or metabolic acidosis with respiratory compensation, and so on. For metabolic acidosis, we next calculate the anion gap. A normal value is around 12. This is common in ICU patients and in the elderly, and can lead to missing a high anion gap metabolic acidosis. So please use the correction formula too. For example, albumin is 2, you should add 5 to the anion gap. Just knowing this dramatically reduces diagnostic error. So we classify metabolic acidosis into 2 groups: high anion gap metabolic acidosis and normal anion gap or non-gap metabolic acidosis. I'll upload a separate video that explains this in detail, so please watch that one as well. So today, let's focus on understanding the overall flow. Okay, this is almost all interpretation of ABG. I wrote 1 point, understanding compensation roughly, the 1-2-4-4 rule. To understand the overall picture, a simple rule is helpful. In respiratory disorder, compressed excitation exists, but for now, just remember 1-2-4-4 pattern: acidosis, alkalosis, acute or chronic. 1, 2, 4, 4. It represents how much bicarbonate changes when CO2 changes by 10. Example, PCO2 55 and bicarbonate 25. In acute respiratory acidosis, when CO2 elevated 10, bicarbonate increase 1 as compensation. So this fits respiratory acidosis with renal compensation. In metabolic acidosis, respiratory rate is very flexible and quick. PCO2 is within 25 to 55. For example, if CO2 elevated to 70, it's over. So it's over compensation, means perhaps the patient has chronic respiratory disease like COPD. This is a very simple clinical approach to blood gas interpretation. The key points are form a hypothesis, check the numbers. If they don't fit, go back and reassess the patient. Blood gas analysis helps us avoid missing hidden sepsis, DKA, or respiratory failure. It is a powerful tool in emergency and clinical care. In this video, we focused on understanding the overall picture. For those who want to go deeper, I will create a separate power nap video where we cover anion gap. If you are interested, please check that video as well. Try applying this way of thinking to blood gas analysis, something that may have felt difficult until now. Even if your interpretation isn't perfect yet, you'll notice that you can quickly grasp the patient's overall picture. Stay calm at first. See you in the next video.